Good day, everyone. Last week, we discussed cell wall synthesis inhibitor antibiotics. This week, we're going to be discussing protein synthesis inhibitors, nucleic acid synthesis inhibitors, and your antimicrobacterials. Very sorry about my voice or medyo husky siya. At yung kasi napakiramdam ko for the past few days. So I hope you can bear with it. And we will be discussing a lot of medications today, so I hope you take down notes as we discuss them one by one. Let us review your central dogma. So if you can still recall, no, yung central dogma natin is the process by which your DNA is converted to proteins. Okay? So your DNA is first replicated into another copy. So there are several antibiotics that inhibits the enzyme of replication. After being replicated, your DNA is transcribed into a messenger RNA. Now, from the messenger RNA, so this is carried to your ribosome. Your ribosome is the protein synthesis apparatus of the cell. So this is where your protein is being synthesized from a messenger RNA. Okay? And the ribosome of bacteria differs from that of humans. If we can still recall, yung bacterial ribosome natin is composed of 30 S ribosomal subunit and 50 S ribosomal subunit. Okay. While in the humans or eukaryotes, it's 40 S ribosomal subunit and 60S ribosomal subunit. So this is the basis of selective toxicity of your protein synthesis antibiotics. Okay. So there are several enzymes acting on your DNA replication, if you can still recall from your bio classes, like your topoisomerase, which relieves the supercoiling of our DNA, your helicases, and the others. But I want you to remember your topoisomerase. Okay, we have antibiotics that act or inhibit this enzyme. Okay, your topoisomerase 2, also known as your DNA kinases, and topoisomerase 4. Okay, next is your transcription. Okay, if you can still recall, it's the process by which your DNA is transcribed into mRNA. Okay, and this mRNA, and then this mRNA is translated by the ribosome into proteins by reading the nucleotide peptide code codon. Okay, this codon codes for a specific amino acid. Now, this tRNA, the transfer RNA, brings the individual amino acid to the A site. You can see in the picture. The A site or your amino acyl site. Okay, then this amino acid forms peptide bond with the growing polypeptide chain in the peptidyl site or the P site. Okay, and then the empty tRNA in the P site is freed and the ribosome moves to the next codon. And this process is repeated until your ribosome encounters a stop codon. I hope you can still call this translation. So this is the summary of the things that we will be discussing today. So last time, we discussed your cell wall synthesis inhibitors and membrane integrity disruptors. For this week, we will discuss your protein synthesis inhibitors, okay? Your nucleic synthesis inhibitor, yung mga antifolate natin like your sulfonamide and trimethoprim. Your fluoroquinolones, quinolones, rifampin, and your metronidazole. So don't worry, I'll be providing you a memory aid para mas madali sila i-memorize mamaya. Let us discuss your protein synthesis inhibitors. Okay, we have this memory aid from some books. Using this one, buy at 30, sell at 50. So yun. Antibiotics that acts on 30S ribosomal subunit are aminoglycosides, tetracyclines. Okay. while the agents that acts on the 50S ribosomal subunit are your chloramphenicol, clindamycin, erythromycin, and your excuse me, lincosamides. Personally, I'm using this memory aid. Okay, so I've been using this one since I'm in my undergrad. Okay, TAC-CLOPS. The agents that acts on the third test ribosomal subunit are your TA, okay, T for tetracyclines, A for aminoglycosides, okay, and the agents that acts on the 50S ribosomal subunit are your CLOVs, so the chloramphenicol, lincosamides, which includes your clindamycin, oxazolidinones, okay, your macrolides, kasama dito sila azithromycin, clarithromycin and erythromycin, and lastly your streptogramins. So this will be our topic outline for today. Yung topic outline natin is based on my memory aid. So don't be confused when you read the book. The arrangement of the medications is different. Okay? So again, TAC-CLOVs. TA, yeah, tetracycline and aminoglycosides acts on the third ribosomal subunit. Excuse me. So we have several agents under your tetracyclines. We have your tetracycline, doxycycline, minocycline, tetracycline, demeclocycline, kasama din dito si oxytetracycline, and the others. Under your aminoglycosides, we have a lot of aminoglycosides, but the most common or the more common agents are the following. No? So I have a memory aid for this one, GTOX, okay, G for gentamicin, T for tobramycin, A for amicacin, or amicacin, N for neomycin, K for kanamycin, and S for streptomycin and respectinomycin. By the way, those aminoglycosides with a suffix or their name ends with MICIN, they are isolated from micromonospora. Okay. Yung aminoglycosides naman natin that ends with MYCIN, mycin, they are isolated from streptomyces. And then we have your chloramphenicol, lincosamides, okay, oxazolidinones, macrolides, and streptogramins. They act on the 50S ribosomal subunit. Okay, under your lincosamide, we have your clindamycin, your oxazolidinones, we have your linezolid, okay, and your macrolides, meron na naman ako number 8, your trace. Okay, erythromycin, roxithromycin, azithromycin, clarithro, and your erythromycin. So before we proceed, let's read a guide question that we will answer at the end of the discussion. Okay, so this is the most common drug used as an alternative for patients allergic to penicillins. So meron tayong drug classification. So we have drug classification that can be given in patients allergic to penicillin. Okay, so is it erythromycin, doxy, chloramphenicol, or vancomycin? So among them, we discussed already your vancomycin. If you can still recall, your vancomycin is a non-beta-lactam antibiotic. Specifically, it's a glycopeptide which acts on the, can you still recall? The ala terminus of the, okay, peptidoglycan. Okay. And we use your vancomycin as a drug for our MRSA or methicillin resistant Staphylococcus aureus. Next guide question. This is or are aminoglycoside antibiotics derived from Streptomyces species. Discuss na natin to kanina. Okay. Streptomycin ba, gentamicin, or azithromycin? Now let us discuss excuse me, your tetracyclines. If you can still recall, tetracyclines and aminoglycosides acts on the 30S ribosomal subunit. So your tetracycline can be classified based on the duration of action. We have your short-acting, intermediate, and long-acting tetracyclines. Okay, so your tetracyclines binds to the 30th ribosomal subunit of the bacteria and prevents the attachment of your amino acyl tRNA to the acceptor site. Okay, so I want you to focus on the picture sa right side ng screen. So again, your tetracycline prevents the attachment of amino acyl tRNA to the acceptor site or A site. So for memory aid, yung letter A natin is the first letter in the alphabet. And the first antibiotic that we discussed today is your tetracycline. So for tetracycline, A site. Okay, don't forget that one. Next, we have your mechanism of resistance. So some bacteria can develop resistance via the following mechanisms. Number one, impaired influx, so they prevent the entry of the tetracycline or they can increase the efflux of the antibiotic. So itong efflux na discuss natin ito last week. And then number two, they can develop ribosome protection, preventing tetracycline from binding to its target site. So number three, enzymatic inactivation. Sorry. So the bacteria can develop enzymes that can degrade or inactivate our tetracyclines. So where do we use our tetracycline? So number one, your tetracycline is the drug of choice for rickettsial and borrelial infection. So I hope you can still recall this one from your microbiology, no? The different causative agents. For example, your rickettsial, okay, the causative agent of rickettsia, we can give tetracycline. Okay, for Borrelia naman, your Borrelia recurrentis, the causative agent of Lyme disease. So the drug of choice is your tetracycline. We can also give tetracycline to chlamydial infection like Chlamydia psittaci, the causative agent of your parrot disease, okay? Your Mycoplasma pneumoniae or your atypical pneumonia, walking pneumonia, H. pylori or Helicobacter pylori, Vibrio cholerae, the causative agent of your cholera, and your Treponema pallidum, the causative agent of syphilis. Your demeclocycline naman is given in patients with serum of inappropriate antidiuretic hormone secretion. So this one, na-discuss natin to sa midterms, no? I hope you can still recall si adage. Okay? Next, we have your doxycycline. So your doxycycline is famous as a malaria prophylaxis. So if you will visit a place where malaria is endemic like in Palawan, you are advised to take doxycycline as prevention, no? Prophylaxis ng malaria. Okay, it can also be given as a post-exposure prophylaxis in leptospirosis. For example, lumusong kayo sa baha, no? You wade on floodwaters. So you can be given with doxycycline to prevent leptospirosis. By the way, sino gani ang causative agent ng ating leptospirosis? Your Leptospirosis interrogans. So I hope you are familiar with the different causative agents. Next, we have your minocyclines that can eradicate meningococcal carrier state. And lastly, we have your tetracycline, which is given in patients with MRSA, okay, or your methicillin-resistant Staphylococcus aureus, and your vancomycin-resistant Enterococci and anaerobes. So your tetracycline is famous for causing GI discomfort, like diarrhea, abdominal pain, and they are very famous for causing this stunted growth and discoloration of teeth in the young. Okay? So they are readily bound kasi, yung tetracyclines natin, they are readily bound to the calcium in growing bones and teeth. That is why itong mga medications na ito are contraindicated in pregnant patients and those patients who are less than 18 years old. Okay? It can also cause photosensitivity, vestibular toxicity, and superinfection. Since your tetracycline is a broad-spectrum antibiotic, it can also kill your normal flora, lalo na sa gut, no? So pag namatay yung normal flora natin sa gut, pathogenic bacteria can proliferate, like your Clostridium difficile, which is the causative agent of your Pseudomonas colitis. Next, Fanconi syndrome. This is seen in patients who are taking expired tetracyclines. So they can develop acute tubular necrosis, nephrotoxic. And then they are nephrotoxic with patients taking diuretics. So I hope you can still recall the diuretic, no, the group of diuretics that can cause nephrotoxicity. Lecture natin sa prelim. Okay? So for notes, please take note that your tetracycline, the absorption of your tetracycline is impaired by multivalent cations like calcium, magnesium, iron or ferrous, and your aluminum. So we must not co-administer tetracycline in medications containing multivalent cations like, say for example, ano man, antacids, very good. Your iron preparation, yung mga ferrous sulfate natin, ferrous gluconate, and lastly, in dairy preparation. Okay, so you can advise this to your patients. And number two, absorption of tetracycline is impaired by food. So you advise tetracycline to be taken before meals or 30 minutes after meals, except for doxycycline and minocycline. So the absorption of these two is not impaired by food. Tetracycline are excreted mainly in the bile and the urine, okay, except for your doxycycline and tetracycline. They are eliminated by non-renal mechanism. So we don't need any adjustment in patients with renal failure. Now let us discuss your aminoglycosides. So if you can still recall your aminoglycosides, if it ends with MICIN, it's isolated from Micromonospora. And if it ends with MYCIN, it's isolated from Streptomyces. Okay, for memory aid, yung aminoglycosides natin ay your G-TAMs. G for gentamicin, T for tobramycin, A si amikacin, N neomycin, K for kanamycin, S for streptomycin, and spuctinomycin. So your aminoglycoside along with your tetracycline binds on the 30S ribosomal subunit of your bacteria. Specifically, your aminoglycoside irreversibly inhibits the formation of your initiation complex. Okay, so don't forget this one. It also causes misreading of mRNA and it can block translocation. Some bacteria can develop resistance to aminoglycoside by producing transferase enzyme that can degrade their aminoglycosides. They can also impair the entry of the drug. And number three, they can alter the receptor of this drug to prevent it from binding. So where do we use our aminoglycoside? So number one, your gentamicin is used mostly for gram-negative organism. So it is usually combined with a beta-lactam antibiotic, si ampicillin, no? In patients with neonatal sepsis. So I can still recall when I was still affiliated with a local hospital, we are prescribing gentamicin along with ampicillin, okay, for neonatal sepsis. Yung tobramycin naman natin and your neomycin is reserved for topical agent, no? Because they are very toxic, no? Nephrotoxic, vestibulotoxic. Okay. Your amikacin, kanamycin, and streptomycin, okay, silang tatlo, are reserved for second-line treatment for tuberculosis. So this is given in patients with resistant TB. Okay? Yung streptomycin din natin is given in patient with plague, tularemia, and your brucellosis. So I hope you can still recall the positive agents of these three, no? Based on your microbiology. So si plague is caused by your Yersinia pistis, si tularemia naman, also known as your rabbit fever, it is caused by Francisella tularensis. Okay, so don't forget that one. Aminoglycosides are nephrotoxic, especially if they are co-administered with other nephrotoxic agents like your diuretics. It can also cause neuromuscular blockage, like your curare derivatives, no, sila tubucurare and the others. So once the patient develop neuromuscular blockage, we can reverse this one by giving calcium gluconate and histamine. It can also cause auditory damage and vestibulotoxicity. So yung auditory damage natin, the symptoms are the following. The patient can develop tinnitus or ringing of the ear. Pag vestibulotoxicity naman natin, the patient can develop ataxia or loss of balance. Okay? For memory aid, those agents that cause auditory damage are your kanamycin, amikacin, and your neomycin. Okay? Sila kan. Okay? Kan or lata. So pag may lata ka sa tenga, parang nagre-ring yung tenga. Okay? So if you have can in your ears, parang nag-ring yung ears. So auditory damage. Aminoglycosides are poorly absorbed in the gut. That is why they are frequently administered as parenterans. They also have limited tissue penetration, lalo na sa brain. So they are not the agent used in meningitis. They are mainly excreted by the kidneys. So when the patient has renal failure, we need to adjust the dose of aminoglycosides. Next, they require oxygen for uptake. So they are not the agents of choice for anaerobic infection because of this oxygen requirement. Next, yung aminoglycoside natin, they exhibit concentration-dependent killing. So what does this mean? No? As the plasma level of your aminoglycoside increases, the killing power of your drug also increases. Okay? So directly proportional yung dosage natin sa kanyang effect. This is compared to your penicillin, which has a time-dependent killing. Pag sinabi naman natin time-dependent killing, the effect of your penicillin and your cephalosporins pala, your penicillins and cephalosporins, no? The effect is directly related to the time above the minimum inhibitory concentration. So their effect is independent to the concentration. Okay? Second. And your aminoglycoside, along with your fluoroquinolones, has a post-antibiotic effect. No? Anong ibig sabihin pag sinabi natin post-antibiotic effect? Their killing action continues when their plasma level have declined below measurable levels. So yung action nila continues. Kahit di mo na ma-measure yung drug. Okay, that's your fluoroquinolones and your aminoglycoside. So again, yung aminoglycosides natin are synergistic with cell wall inhibitor antibiotics like your penicillins and cephalosporins. And your amikacin has the narrowest therapeutic window among your aminoglycosides. Now let us discuss your chloramphenicol. Okay, now we are discussing the agents that acts on the 50S ribosomal subunit of your bacteria. The first agent is chloramphenicol. Chloramphenicol specifically blocks, blocks the peptidyl transferase at 50S ribosomal subunit, preventing translocation. So mechanism of resistance, some bacteria develop acyl transferases that can inactivate the drug. So we use your chloramphenicol and meningitis like Streptococcus pneumoniae, influenza, and meningitis. But we rarely use your chloramphenicol for this, no? Kasi of its toxicity that I will discuss later. Your chloramphenicol now is reserved as a backup drug for patients with salmonella and rickettsia. So I can still recall dati, the drug of choice for your salmonella typhi, the causative agent of typhoid fever, was chloramphenicol. Now, because of its toxicity kasi and some resistance to chloram, the drug of choice for your salmonella typhi is ceftriaxone. Okay? Toxicities, chloram can cause GI disturbance like diarrhea, okay, abdominal pain, at it can also cause aplastic anemia. Pag sinabi nating anemia, the RBC level, okay, of the patient is low. Okay? This is because your chloramphenicol inhibits the maturation of your red blood cells. Okay? It can also cause gray baby syndrome. So, in babies kasi, in infants, your chloramphenicol is mainly conjugated. Okay, yung phase, if you can still recall no, from your pharmacology 1, pag sinabi ng conjugation reaction, it's your phase 2 no, metabolism. So, yung conjugation natin ng chloramphenicol is mainly via your glucuronic acid pathway in which it is not yet developed masyado in our infants. Kaya pag binigyan sila ng chloramphenicol, they develop pale blue skin, lethargic eyes. Yan yung symptoms ng ating gray baby syndrome. Okay? Notes. Most of the drug is inactivated. Okay, so this was discussed earlier. So again, the drug is mainly inactivated by conjugation with glucuronic acid pathway, which is not yet developed in infants. So pag binigyan mo sila ng chloramphenicol, they can develop gray baby syndrome. And your chloram is a potent enzyme inhibitors. I hope memorize na yung mga enzyme inhibitors natin, no? Sila Medicav. Okay, yung letter C natin doon is your cimetidine and your chloramphenicol. So when you co-administer a drug with an enzyme inhibitor, the metabolism of the second drug is inhibited. So mas mataas yung plasma level niya. Okay? Next, let us discuss your lincosamide. Okay, your lincomycin and clindamycin. Like your chloramphenicol, it also blocks your translocation reaction at 50S ribosomal subunit. But please take note that your lincosamides do not inhibit your peptidyl transferase like your chloramphenicol. Okay, the site of action of this drug is adjacent to your peptidyl transferase, but it does not inhibit the enzyme. Okay. Some bacteria develop resistance to your clindamycin primarily by mutation of ribosomal receptor site. And number two, they can develop enzymes that can degrade these medications. Okay, uses. So where do we use our clindamycin? Primarily. So we use this primarily on anaerobic infections, lalo na in aspiration pneumonia, lung abscesses, and oral infection. So there's a memory aid for you to remember. So if the anaerobic infection is above the diaphragm, we usually give clindamycin. Okay? If the anaerobic infection is below the diaphragm, so we give metronidazole. Aside from that, we also give clindamycin in patients with soft tissue and skin infection caused by streptococci and staphylococci, especially yung mga MMSA natin or yung methicillin sensitive Staphylococcus aureus. Okay, so aside from your penicillinase resistant, we can also give clindamycin for those type of infections. Toxicities, so your clindamycin is famous for causing pseudomembranous colitis. along with your PC. So how do we treat no your pseudomembranous colitis? You can still recall the causative agent of this one is your Clostridium difficile. We can give vancomycin, but please take note it must be in oral preparation. Okay? Vancomycin PO or metronidazole. So again, anaerobic infection above the diaphragm, excuse me, we give clindamycin. Okay, below the diaphragm, we give metronidazole. Let us discuss your oxazolidinones, okay, your linezolid. Mode of action, like your chloramphenicol and gossamer, it also acts on your 50s ribosomal subunit. So we are usually reserving linezolid for our gram-positive superinfections o yung mga resistant natin. Okay? Sila MRSA and your vancomycin resistant enterococci. Sa toxicities, it can cause thrombocytopenia. Pag sinabi nating pinya, mababa ang level, okay? Thrombocyte, it's your platelet. So low level of platelets, peripheral neuropathy, and your linezolid is famous for causing serotonin syndrome. Okay, excessive serotonin secretion that can lead to diarrhea, okay, hyperthermia, pwede din sa cognitive dysfunction like delirium agitation. That is the serotonin syndrome. Excuse me. Okay, now let's discuss your macrolides. Okay, sila telithromycin, which is a synthetic macrolide or acutolide, your erythromycin, roxithromycin, and the common macrolides prescribed on our setting, sila azithromycin, prescribed once a day, your clarithromycin prescribed twice a day, your erythromycin prescribed 3 times a day. So all of this medication inhibits your 50S ribosomal subunit by binding near at the peptidyl transferase, thereby inhibiting your translocation reaction. So your macrolides, please take note, do not inhibit your peptidyl transferase like your lincosamides, but your lincosamides. Okay, but your chloramphenicol, lincosamides, and your macrolides all inhibit your translocation reaction. Okay, nagkakatalo lang sila sa peptidyl transferase. Another special thing about your macrolides is that they bind to the 23S of your rRNA of the 50S ribosomal subunit. So where do we prescribe or where do we give when do we give your macrolides? Now when the patient is infected with atypical pneumonia. So pag sinabi nating atypical, this type of pneumonia do not present the usual symptoms. So before we discuss it further, let us first discuss your typical pneumonia. Your typical pneumonia is usually caused by Streptococcus pneumoniae. Okay? And these patients infected with typical pneumonia presents with classic symptoms like fever plus high grade, cough plus high grade fever and sometimes chest pain. Okay? Yung atypical pneumonias naman natin, yung mga patients na to, they usually present with only cough, no? And sometimes they are well looking with low grade fever or sometimes they are afebrile or walang fever. Kaya yung other name ng atypical pneumonia natin is walking pneumonia kasi they are well. But when you look at the chest x-ray of these patients, so napakarami, daming infiltrates. So I have this one patient last week with atypical pneumonia. She just presented with the chest pain. Okay, when I check her lungs, no, when I auscultated her lungs, so I heard parang what we call crackles or medyo may tubig sa baga. And when I ordered chest x-ray, so napakadumi din. So it is a classic, no, atypical pneumonia. The patient just presented with chest pain. She was swell. Okay, sometimes with occasional cough pala. So when I ordered chest X-ray, yun napakaroon eh. I prescribe her with a macrolide. So we can also give macrolides in patient with chlamydia trachomatis. So this is a sexually transmitted infection. So we can also give your macrolides in Bordetella pertussis, the causative agent of your whooping cough. Okay, and please take note of this one. We give your macrolides in patient who is allergic to penicillin. So this is a substitute for patients with penicillin allergy infected with gram-positive cocci. So for the side effect of your macrolides, just remember macro. Okay? They can cause gastrointestinal motility issues, okay, arrhythmia. If you can still recall, your macrolides, your antibiotic is part of your A, B, C, D, E, no? Yung letter A natin doon is your antibiotics, specifically yung macrolides natin. Okay? So they can cause torsa de pois. They can also cause cholestatic jaundice, lalo na yung stolate salt of your erythromycin. Okay. It can also cause rash and eosinophilia. So just remember macro. Notes, all of your macrolides are inhibitors of CYP450 except your azithromycin. So again, please take note of this one. All of your macrolides are enzyme inhibitors except for your azithromycin. The stearate salt of erythromycin is the best oral absorption, but okay, it causes cholestatic jaundice. Kaya wala na tayong stearate salt na erythromycin. And just a trivia, no, na-discuss ito kanina, your erythromycin was first discovered in Iloilo. That's why the first brand name of your erythromycin is your Ilosol. Just nice. Okay, next, the last one and on our fifth test ribosomal subunit, your streptogramins. No, sila quinopristine, a streptogramin B, and your dalfopristine, streptogramin A. So they share the same binding site with the macrolide and lincosamide. So it also inhibits your translocation. And this one are reserved like your your linezolid. It is also reserved for gram-positive superbugs like your MRSA and your vancomycin resistant enterococcus. Toxicities, pain at the injection site, okay? Arthralgia, myalgia symptom. Pag sinabi natin arthralgia, pain on the joint, okay? Myalgia, pain on the muscle. Elimination is primarily by fecal route. That is why, no, if the patient has renal failure, we don't need to adjust the dose. Okay? And your streptogramins is also an enzyme inhibitor like your macrolides, except for azithromycin. Okay? Okay, before we answer our guide questions, let us a quick review of our protein synthesis inhibitor antibiotics. For memory aid, just remember tacloms. The first two, your tetracycline and aminoglycosides, inhibit the 30S ribosomal subunit, while the cloms or chloramphenicol and cosamides, oxazolidinones, macrolides, and streptogramins inhibits your 50S ribosomal subunit. By the way, I think I forgot to mention, all of your protein synthesis inhibitors are bacteriostatic except for aminoglycosides and your streptogramins. Okay? Sige. Yung tetracyclines natin, if you can still recall, they inhibit your, they prevent the binding of your amino acyl tRNA to your A site at 30S ribosomal subunit. While your aminoglycoside naman blocks the formation of the initiation complex at the 30S ribosomal subunit. Next, we have your 50S ribosomal subunit inhibitors, sila CLOMS, sila CLOMS, sila chloramphenicol, which blocks your peptidyl transferase, no, thereby inhibiting your translocation, your lincosamides, the lincosamide like your clindamycin, which inhibits translocation, but it does not inhibit your peptidyl transferase like your chloramphenicol. Okay, it only binds near the peptidyl transferase. Next, we have your oxazolidinones, no, sildenafil. Okay. It is usually reserved for superinfection caused by gram-positive species, no, like your MRSA and your vancomycin-resistant enterococci. Yung macrolides natin, okay, letter M for macrolides, it also binds at the 50S ribosomal subunit near the peptidyl transferase, thereby inhibiting the translocation like your lincosamides. Okay, this is usually given in patients allergic to penicillins. Next, we have your streptogramins. Okay, it is also reserved in resistant gram-positive infection like MRSA and VRE. Okay, so yun. So let us answer our guide question number 1. So this is the most common drug used as an alternative for patients allergic to penicillin. Okay, na-discuss natin to bago lang. Okay, so we give your macrolides. No, sila erythromycin, doxystromycin, roxystromycin, si azithromycin, clarithromycin, and erythromycin. So this is the correct answer, letter A, erythromycin. Guide question number 2. These are aminoglycoside antibiotics derived from Streptomyces species. So madali lang to. So again, if the aminoglycoside ends with MICN, it is isolated from Micromonospora. Okay, pag nag-end naman sa MYCAS, it is isolated from Streptomyces. So the correct answer here is 1 only. So letter A. So bakit mali itong number 3? Kahit na nag-end siya sa MYCIN. Because your azithromycin is a macrolide. Okay, not an aminoglycoside. Okay? So next. Now let us discuss your nucleic acid synthesis inhibitors. So medyo short lang ito. Before we proceed, let's read a guide question that again we will answer at the end of the discussion. What is the mechanism of action of quinolone antibacterial agent? Is it A, inhibit the incorporation of GABA into your dihydropteroate? Letter B, inhibit the bacterial enzyme topoisomerase 2? Letter C, inhibit the DNA-dependent RNA polymerase of the bacteria? Letter D, inhibit the transpeptidation process in bacterial cell wall synthesis. And letter D, inhibit bacterial dihydrofolate reductase. Please remember your quinolones and fluoroquinolones has the same mode of action. Pag sinabi nating fluoroquinolones, it's just fluorinated, okay, quinolone. This is our topic outline for our nucleic acid synthesis inhibitors. We have your sulfonamides and your trimethoprim and your pyrimethamine. They are also known as your antifolate drugs because they inhibit or they prevent the formation of folic acid on bacteria. Okay, so your sulfonamides and your trimethoprim and pyrimethamine. Okay, your quinolones naman, meron tayong first, second, third, and fourth generation. Okay. Medyo madami din siya like your cephalosporin. But, okay, compared to your cephalosporin, yung quinolones natin, as the generation increases, the gram-positive activity also increases. Okay, that is in reverse to your cephalosporin, if you can still recall. As the generation increases, okay, the gram-positive activity decreases, pero hanggang third generation lang. We will also discuss your metronidazole and your rifampin. So medyo mabilis lang to. Now let's discuss your sulfonamides, okay? Along with your trimethoprim and pyrimethamine, they are known as your anti-folate drugs because they prevent the formation of folic acid. By the way, your bacteria can produce their own folate or your folic acid. Compared to human, we need to take it exogenously by based on diet or through vitamins. This is also the basis of the selective toxicity of your sulfonamides and trimethoprim. So let us review the process on how the bacteria produces folic acid from your PABA. So from PABA or your para-aminobenzoic acid, okay, they can produce dihydrofolic acid using your dihydroteroid synthase. And this is inhibited by your sulfonamides. From your dihydrofolic acid, okay, they can produce tetrahydrofolic acid using your dihydrofolate reductase. And this enzyme is inhibited by your trimethoprim. And from your tetrahydrofolate, they can produce purine and then DNA. So where do we use our sulfonamide? Okay. By the way, your sulfonamides, when given alone, is a bacteriostatic, but when it is combined with your pyrimethamine or your trimethoprim, they have a synergistic action and they become bactericidal. So, sorry, bactericidal. So again, where do we use our sulfonamide? So number one, it's the drug of choice for your pneumocystis carini pneumonia. This is usually seen in AIDS patient. And by the way, your pneumocystis carini has a new name. Your pneumocystis jirovecii. So the drug of choice for your pneumocystis carini pneumonia is sulfamethoxazole plus trimethoprim, also known as your cotrimoxazole. Okay? Aside from that, your cotrimoxazole is also given in patients with UTI, respiratory ear and sinus infections caused by gram-negative rods. Okay? So like your E. coli. Next, we have your sulfamethoxazole and pyrimethamine. This is the drug of choice for your toxoplasmosis. Okay, your silver sulfadiazine is given in burn patients to prevent infection. So I can still remember my clerkship years. I was assigned in a burn ward in a public hospital here in Davao. So we are applying silver sulfadiazine to prevent pseudomonal infection because your burn patients kasi are very prone, okay, to develop pseudomonas infection. And then your sulfasalazine is given in patients with inflammatory bowel disease. This is a non-infectious disease. Okay, your IBD. Next, let's discuss the toxicities of your sulfonamides. Okay, your sulfonamides can cause diarrhea, gastrointestinal pain, abdominal pain, and they are famous for causing acute hemolysis in G6PD patients. No? So when you give sulfonamides and other sulfa-containing drugs in patients with G6PD, okay, they are prone to hemolysis. That is why they are contraindicated. So be careful, in dispensing drugs that is contraindicated in G6PD deficiency patients. Okay? Your sulfonamides can cause nephrotoxicity, photosensitivity, Steven Johnson syndrome. So I will show you a picture of your SJS later, and your kernicterus in infants. So what is kernicterus? So when administer sulfonamide in infants, no, your sulfonamides kasi can displace, okay, your they can displace your bilirubin, okay, from your albumin. And the excessive amount of bilirubin in the blood can be deposited in the brain of the patient. So again, yung sulfonamides natin can displace the bilirubin bounded to your albumin, okay, and this can cause excessive bilirubin levels in the blood that can be deposited on the brain of the patient. leading to mental retardation. Notes, your sulfonamide again are bacteriostatic when given alone and synergistic if given with dihydrofolate reductase inhibitor. So they become bactericidal. They can displace drug from protein like warfarin. Okay, not only drugs, okay? They can also displace your bilirubin from proteins like albumin, causing kernicterus. So this is your Steven Johnson syndrome. Okay, actually, the exact pathophysiology of this entity is not yet discovered. It is usually seen in patients taking sulfa medications, lalo na yung sulfonamides natin. Ito na yung slide. So your kernicterus, once again, is caused by excessive bilirubin levels in the blood. Okay. If the patient was given with sulfonamides, yung sulfonamides natin can displace your bilirubin from your albumin. Okay? And the excessive bilirubin in the blood can be deposited in the brain. Okay? And this will cause mental retardation in the patient. Excuse me. So next, you have your dihydrofolate reductase inhibitors, no? Sila trimethoprim and pyrimethamine. So again, they are the drug of choice for pneumocystis carinii pneumonia. Yung sulfamethoxazole natin plus trimethoprim, also known as your cotrimoxazole. And your sulfamethoxazole plus pyrimethamine, this is the drug of choice for your toxoplasmosis. Now, let us discuss your quinolones and fluoroquinolones. Like your cephalosporins, meron din siyang generations. First to fourth. As the generation of your quinolones increases, the gram-positive activity also increases. This is in reverse to your cephalosporins, if you can still recall. As the generation of cephalosporins increases, the gram-positive activity decreases, while the gram-negative activity increases. Okay? So, yeah. The mode of action of these antibiotics is that they inhibit your topoisomerase 2, also known as DNA gyrase, preventing the relaxation of supercoiled DNA, and it also inhibits your topoisomerase 4 that prevents the separation of replicated chromosomal DNA, leading to the inhibition of bacterial DNA synthesis. Your quinolones and fluoroquinolones is contraindicated in pregnant patients and those who are planning to be pregnant and those patients who are less than 18 years old because it can cause cartilage damage leading to tendonitis and tendon rupture. So please remember that, okay? Your quinolones and fluoroquinolones can cause cartilage damage. While your tetracycline, if you can still recall earlier, can cause um, enamel destruction and stunted growth because they readily bind to calcium in the growing bone and in teeth. Okay? It also causes GI upset like abdominal pain, diarrhea, and skin rashes. Okay, again, with increasing generation of your quinolones, the gram-positive activity increases. They also exhibit post-antibiotic effect like your aminoglycoside, no? If you can still recall. So ito, na-discuss natin ito kanina. And lastly, the oral absorption of your quinolones is impaired by cations like your tetracyclines. Okay, uses. So yung first generation natin is usually active against pathogens that causes UTI. But we don't use your first generation na because a lot of microorganisms are resistant to this. Okay, so we are using second generation against gram-negative microorganism, lalo na meron siyang Pseudomonas activity. Actually, some of the doctors will prescribe second-gen quinolones against UTI, okay, your E. coli. Can also be used against gram-positive cocci, okay, yung mga causes of pneumonia, and your atypicals. Sila chlamydia, mycoplasma, and your legionella. And third generation, also known as respiratory quinolones, because they are active against lung infection caused by gram-positive cocci, like your Streptococcus pyogenes. Okay, they're also active against atypicals, and they are second line for tuberculosis, like your aminoglycoside. Okay? Meron din silang MRSA coverage. Don't worry, we will discuss your anti-tuberculosis medication later. Lastly, your fourth generation is the broadest spectrum. Okay, they can cover gram-negative microorganism, gram-positive organism, and lastly, meron na silang anaerobe activity. Okay, next, let's discuss your metronidazole. So ito metronidazole, not only it's a bactericidal, it's also an anti-protozoal. Okay, it forms a free radical metabolite in the bacterial or protozoal cell that damages the DNA. Okay, it's a drug of choice for your Giardia, okay, Giardia lamblia, Entamoeba, okay, Entamoeba histolytica, and your Trichomonas. It can also be used, no, in patients with vaginitis caused by your Gardnerella vaginalis, an anaerobe infection. So if you can still recall, I hope na-discuss ko to kanina, no? If the anaerobic infection is below, okay, below the, what do you call this one? Diaphragm, okay, we usually give metronidazole. Okay, if the anaerobic infection is above the diaphragm, we give clindamycin. So your metronidazole can cause metallic taste. So this is one of the most common cause, no, of stopping the medication kasi ayaw nila yung lasa ng gamot. Okay, unlike your cephalosporins, they can cause a disulfiram-like effect. Okay, next, you have your rifampin and other rifamycins, like your rifampicin. Okay, all of them inhibits your RNA polymerase, your DNA-dependent RNA polymerase. So their primary use is for tuberculosis. They can cause orange bodily secretions, so orange tinge urine, orange tinge na sweat, okay, pati laway and your tears, no? And they can also cause hepatotoxicity. Your rifampin and rifampicin is a potent enzyme inducer. So I hope by now, no, alam nyo na yung effect ng enzyme inducer if it is co-administered with another or a second drug. Let us answer our guide question. So what is the mechanism of action of quinolone antibacterial agents? Okay, letter A, inhibit the incorporation of GABA into your dihydroteroate. So is this correct? So this is incorrect. So this is the mode of action of your sulfonamides, no? By inhibiting your dihydroteroate synthase. Okay? Letter B, inhibit the bacterial enzyme topoisomerase 2. So this is correct. Okay, your quinolones inhibit your DNA gyrase or your topoisomerase 2 and your topoisomerase 4. Okay? Letter C, inhibit the DNA-dependent RNA polymerase of bacteria. So this is the mode of action of your rifamycin, like your rifampin and rifampicin. Okay, letter D, inhibit the transpeptidation process in bacterial cell wall. So this is the mode of action of your beta-lactams. Okay, letter E, inhibit bacterial dihydrofolate reductase. Ito naman, it's the mode of action of your trimethoprim and your pyrimethamine. Now let's proceed to our third topic, your antimycobacterial agents. So actually, I lifted some tables from our National Tuberculosis Program guidelines. Medyo endemic kasi yung tuberculosis sa atin. Napakaraming cases nito. So I think we will be discussing the drugs and the duration of drugs slightly more thoroughly. and we will try to uh, correlate it with our local setting. Okay, so our guide question for this topic: which of the following drugs given for tuberculosis is metabolized by the liver? Enzyme N-acetyltransferase, whose expression is genetically determined, uh, may vary in different population. So if you can still recall, no, itong N-acetyltransferase natin is the enzyme responsible for one of our conjugation reaction, yung ating acetylation. Okay? So the question is asking here kung which of the following medication is affected if a patient is a fast acetylator or a slow acetylator. Okay, so pwede din, the question is asking which of the following is metabolized via your acetylation. Yan na lang, mas madali. Okay, is it A, isoniazid? Letter B, is it rifampicin? C, ethambutol? D, pyrazinamide? And E, your streptomycin. Your Mycobacterium tuberculosis, okay, is the causative agent of your TB. So meron tayong two forms, no? It can be pulmonary tuberculosis, which affects mainly our lungs, or it can be extrapulmonary TB, no? Yung outside the lungs. And the most common extrapulmonary TB is your scrofula. Yung scrofula is the infection of cervical lymph node, no, sa may leeg banda. So this is a picture on the bottom side of your screen. So this is a picture of primary tuberculosis, no? If you can see, meron siyang cascating necrosis. So usually yung lesion ng ating tuberculosis para siyang chalk, inconsistency. Okay? So this will be our topic outline for today. We will discuss your drugs for tuberculosis, your first line and second line drugs. Yung first line drugs natin are your isoniazid, okay, rifampicin, pyrazinamide, and your ethambutol. So this is your first line drug. So please also please remember the other names, no? Yung specifically yung mga letters na ng ating first line agent. Kahit yung first line agents lang. We will also discuss the drugs used in leprosy, and lastly, the drugs used for non-tuberculous mycobacteria, yung ating Mycobacterium avium complex. Actually, medyo mabilis lang to, no? Medyo madali lang to. So, bear with me, malapit na tayo matapos. So, this is the treatment guideline for our tuberculosis. This is given for patients without any resistance to medication. Meron tayong regimen 1 and regimen 2, okay? So for your regimen 1, it is given for patients with pulmonary tuberculosis or extrapulmonary tuberculosis except for the central nervous system, bones, and joints. So we have 2 months of intensive therapy followed by 4 months continuation therapy. A total of 6 months. So 2 months of HRZE or your isoniazid, rifampicin, pyrazinamide, and your ethambutol, followed by a 4 months of isoniazid and rifampicin alone. Okay? So don't forget this one. This is your regimen 1 for pulmonary tuberculosis or extrapulmonary tuberculosis that is not CNS, bones, or joints. Okay? So for extrapulmonary tuberculosis of the CNS, bones, and joints, medyo mahaba yung treatment natin. It's a total of 1 year or 12 months. Okay? So again, 2 months of intensive therapy, yung ating HRZE, followed by 10 months of your continuation phase, yung HR natin, isoniazid and rifampicin. Okay? So I will also require you to memorize the what do you call this one? prescribe, okay? Prescribe dose of each of the first line medication. Kasi lumalabas sila sa board exam. For example, si isoniazid, okay, please memorize 5 milligram per kilogram na dose, no? Per day. Okay, ha? Isoniazid, 5 milligram per kilogram. Okay, your rifampicin, it's 10 milligram per kilogram. Okay, pyrazinamide, it's 25 to 25 milligram per kilogram. And lastly, your ethambutol, 15 milligrams per kilograms. Okay, so please memorize the add-on kasi lumalabas siya sa exam. Excuse me. So please take note that your streptomycin is not included on our first-line drugs against tuberculosis. A long time ago kasi your streptomycin was included on our first-line medication. Okay, now your streptomycin is a second line. It is reserved for those who are allergic to the medications on first line natin or those with toxicities no, after administration of first line drug or those who are resistant to our first line medications. So ito yung summary ng ating first line drugs against tuberculosis. Your isoniazid acts on the mycolic acid synthesis. Your ethambutol acts on the arabinosyl transferase. Your rifampicin acts on the RNA polymerase. And lastly, your pyrazinamide, dati, no? Unclear daw yung mechanism. But now, okay, we have a distinct mode of action for your pyrazinamide. Okay, so this again your first line drugs for tuberculosis. And ito naman yung mga second line drugs against TB. So I will require you to memorize the first line drugs. Their other name, especially yung one letter, excuse me, especially yung one letter, no? And for the second line drugs, I will not require you to memorize the other names. Okay? So for your second line drugs, yung novel natin dito is your bedaquiline and your delamanid. So ito yung mga bago nating medications for tuberculosis. Yung other dito na-discuss na natin like your streptomycin, your amikacin, and your kanamycin. All of them are aminoglycosides. Very good, no? Your levofloxacin is ano to? Quinolone, no? Fluoroquinolone. Anong generation? So very good. It's a respiratory quinolone or your third generation. Clofazimine, it is also given in patients with leprosy. Okay, your linezolid, na-discuss din natin to kanina, ha? Your cycloserine, it's a cell wall synthesis inhibitor. Your prothionamide, discuss natin mamaya, and your para-aminosalicylic acid. Now, let us discuss your isoniazid. Okay, it is one of your first-line drugs against your tuberculosis. Your isoniazid is the most active drug against TB because it can penetrate the insides of your macrophage. If you can still recall from your micro lecture, yung TB bacilli natin can hide inside your macrophage. So yung isoniazid natin is active against both your intracellular TB bacilli and your extracellular TB bacilli. Yung isoniazid natin is a prodrug. It needs an enzyme in order to become the active drug moiety. Okay? It needs your CatG. It is a catalase peroxidase enzyme. And the active drug inhibits the INHA and your Cas-A. Both of them are acyl carrier protein reductase needed for mycolic acid synthesis. So by inhibiting these two carriers, your isoniazid inhibits your mycolic acid synthesis. So please remember, isoniazid inhibits mycolic acid synthesis. Some TB bacilli can develop resistance by producing overproduction of INHA, no? So, ma-defeat yung purpose ng ating isoniazid kasi sobrang dami ng ating INHA. Okay, number 2 is the mutation of your CatG. So yung cat-G is needed for your isoniazid to become active. Toxicities. So your isoniazid is famous for causing drug-induced lupus. So I hope you can still recall yung memory aid natin for the medications that cause drug-induced lupus. Sila HIPs, no? Hydralazine, isoniazid, procainamide, phenytoin, and your sulfa medication. Your isoniazid can also cause peripheral neuropathy. So this is treated with vitamin B6 or your pyridoxine. It can also cause seizures and hepatotoxicity. Actually, all of your first-line drugs are hepatotoxic. But there is one medication that is very, very hepatotoxic. Okay, please take note of that. So again, ito, na-discuss natin to kanina, and this one. And your isoniazid is metabolized via your acetylation. So please remember this one. And by the way, the metabolism of your isoniazid based on research, okay, is not affected if you're fast acetylator or slow acetylator. Mayroon siyang effect, but it's a little, almost negligible. Okay, so no worries. Your isoniazid is a potent enzyme inhibitor. So, part siya ng memory aid natin yung Medicav. Next, we have your rifampicin. Your rifampicin is part of your rifamycin. Na-discuss na natin to kanina. Now, it inhibits your RNA polymerase, bacterial DNA-dependent RNA polymerase, leading to the inhibition of RNA synthesis. So, mechanism of resistance, your TB bacilli can develop mutation to reduce drug binding to your RNA polymerase. Toxicities, so itong rifampicin natin, as discussed earlier, can cause orange-colored secretions, like in the urine, saliva, sweat, tears, so orange lahat. Like the other first-line drugs, as discussed earlier, it is also a hepatotoxic agent. Next, you have your pyrazinamide. So, I'm very sorry, kulang lang letter E. Your pyrazinamide disrupts mycobacterial cell membrane metabolism and transport function. So, dati, uncertain pa sila sa mode of action of your pyrazinamide. But ngayon, alam na nila. It disrupts the mycobacterial cell membrane metabolism and transport function. Okay, among all of your first-line drugs against TB, this is the most hepatotoxic, yung pyrazinamide natin. So, pag lumabas sa exam, which of the following are hepatotoxic, tapos lumabas lahat yung first-line drug ng ating tuberculosis, so you answer pyrazinamide because it is the most hepatotoxic, okay? It can also cause photosensitivity and hyperuricemia. So it can exacerbate gout. So I hope you can still recall the diuretic that can cause hyperuricemia. So hindi sila pwedeng ipagsabay, okay? So notes. It's a relative of nicotinamide or your NAD, and it's converted to pyrazinoic acid, which is the active form, and it is the most hepatotoxic first-line drugs against TB. Your ethambutol inhibits mycobacterial arabinosyl transferase responsible for the polymerization of your arabinoglycan. Your arabinoglycan is an essential component of mycobacterial cell wall. So pag na-inhibit siya, okay, the integrity of mycobacterial cell wall is weak. Okay, that is the mode of action of your ethambutol. And the toxicity of your baliktad ha, ethambutol. Una yung letter T. The toxicity of your ethambutol has something to do with your letter E also, your eyes. Okay? It can cause retrobulbar neuritis, loss of visual acuity, and red-green color blindness. Kaya ko to nilagay ay Christmas tree kasi usually yung kulay ng ating Christmas tree is red and green. So you cannot see this color pag due to the toxicity of ethambutol. And by the way, before we prescribe your ethambutol in patients, usually we advise the patient to visit a local ophthalmologist, no, to get a baseline baseline eye function. So para malaman natin na yung decline of eye function is secondary to your ethambutol. So again, ethambutol, letter E, so it is something to do with eyes. Okay? It can cause red-green color blindness. Okay, now let's discuss your second line drugs. So we have your aminoglycosides like your streptomycin, kanamycin, and amikacin. So na-discuss na natin to kanina. They block the formation of initiation complex at 30 as ribosomal subunit. They can also cause misreading of mRNA and blocks translocation. So they are nephrotoxic, okay, and vestibulotoxic and auditory, they can cause auditory damage. So if you can still recall, yung mga may auditory damage natin, sila no? Kanamycin, amikacin, and neomycin. Okay, so they can lead to tinnitus and hearing loss, while your streptomycin can cause, is notorious for causing vestibulotoxicity, leading to vertigo, ataxia, and loss of balance. Okay, and they are nephrotoxic when combined with other nephrotoxic substances. Okay, next we have the two novel antimycobacterial drug, your bedaquiline and delamanid. Your bedaquiline inhibits your ATP synthase, while your delamanid naman, excuse me, blocks mycolic acid synthesis. Your levofloxacin, na-discuss na natin ito kanina. It's a third generation fluoroquinolones, or also known as respiratory quinolone. Okay. Your clofazamine naman is an anti-leprosy that we will discuss more later. Sildenafil, na-discuss din kanina. Your cycloserine naman, it's a cell wall synthesis inhibitor that is mainly reserved for second-line treatment of tuberculosis. We have your prothionamide. Okay, the mode of action of this drug is hindi pa sila masyado certain. And lastly, we have your para-aminosalicylic acid, which blocks the folate synthesis that is active almost exclusively against Mycobacterium tuberculosis. Okay, so guys, I'm requiring you to memorize the first line drugs against pulmonary and extrapulmonary TB, okay, along with their dosage, adult dosage. Okay, so next, let us discuss your leprosy caused by your Mycobacterium leprae. Actually, we have two types of leprosy, no? Yung tuberculoid leprosy natin and your lepromatous leprosy. Okay, this is your tuberculoid leprosy and lepromatous leprosy. So don't worry, I will not ask this one in the exam. I just want you to see, no, the difference between the two. This image was lifted from the web. Okay, your tuberculoid leprosy mostly presents as a well-demarcated patch, and usually the patient has a good immune system. So, ibig sabihin medyo resistant siya against the leprosy. Compared to your lepromatous leprosy, okay, dito mo makikita yung mga disfigurement. Okay? Like this one, no? Kawawa masyado. Mayroon na siyang leonine phases. Okay? And the immune system of this patient is usually suppressed. That is why medyo toxic yung presentation ng sakit. Next, let us discuss the medications against your leprosy. Meron tayong tatlo, no? Dapsone, clofazamine, which is a phenazine dye, and your rifampicin. So your rifampicin, rifampin, another rifamycin was discussed earlier, so I will not be discussing them anymore in this slide. Okay? So your dapsone inhibits dihydropteroid synthase, thereby inhibiting your folate synthesis. So, can you still recall, no? Anong drug or what group of drugs also inhibits your dihydropteroid synthase? It's your sulfonamides. Very good. Now, both of them inhibits your dihydropteroid synthase. Your dapsone is primarily used against leprosy. Pwede din siyang gamitin as a prophylaxis against pneumocystis jirovecii. toxicities like your sulfonamides. They can also cause the exacerbation of hemolysis or hemolytic anemia in patients with G6PD deficiency. Next, you have your clofazimine. Okay, the mode of action is not clearly established. It may interact with DNA or ibang mode of action. Okay, your clofazimine is famous for causing skin discoloration. So usually the patient will present with red, brown, sometimes black. Actually, I saw one patient in a local public hospital with nearly black, okay, skin sa mukha pag yun. Secondary to clofazimine. Okay, so itong tatlong ito are the medications used for leprosy. Actually, meron pa si thalidomide. Okay, we can also use thalidomide for severe leprosy. Okay, next. This is my last topic. Okay, the drugs used for Mycobacterium avium complex. Kaya siya tinawag na complex because it is caused by two mycobacteria, your Mycobacterium avium and your Mycobacterium intracellulare. Normally, they don't cause disease in an immunocompetent person. No? So, nung tumaas yung cases natin ng AIDS and other immunocompromised state, tumaas din yung cases ng ating MAC or your Mycobacterium avium complex. So, again, this is usually seen in patients with HIV AIDS. Okay? So, what are the treatment for your MAC or your Mycobacterium avium complex? So, simple-simple na. Discuss na natin kanina. Clarithromycin plus ethambutol plus rifabutin. Your rifabutin is a rifamycin like your rifampicin. So, same na sila ng mode of action. But I want you to remember the drug of choice for your Mycobacterium avium complex is azithromycin. Okay, a macrolide given once a day because of its long half-life. So I think this is my last slide. Now let's answer the guide question presented earlier. Which of the following drugs given for tuberculosis is metabolized by the liver enzyme N-acetyltransferase, so via acetylation, whose expression is genetically determined, may vary in different population? Is it isoniazid, rifampicin, ethambutol, pyrazinamide, or streptomycin? So the correct answer here is your isoniazid. Okay? So I hope you learned something. So before we end, let us review lang. Okay? Your different antimicrobial drugs. So isoniazid can cause what toxicity? So very good, no? All of your first line drugs can cause hepatotoxicity. But their isoniazid is famous for causing peripheral neuropathy. So it can be treated by giving vitamin B6. The rifampicin naman is famous for causing red-orange urine, okay, or red-orange secretion. Pwede tears, saliva, okay. Your ethambutol naman, sa letter E, it can cause eye problem. Okay, it can cause red-green blindness. Pyrazinamide, it's the most hepatotoxic among your first-line drugs against tuberculosis. And lastly, your streptomycin is an aminoglycoside. Okay, so it can cause nephrotoxicity when given with other nephrotoxic agents. Very good. It can also cause neuromuscular blockage, vestibulotoxicity, and auditory toxicity. So please also memorize nyo yung mga the most auditory toxic drugs and the most vestibulotoxic drugs. Yung nakaparenthesis. Okay, if you have any questions, so wag mahiya magtanong. You can always ask your president to relay your questions to me. So I'm very sorry, medyo na-late ako ng upload because I was not feeling very well for the last days. Na napakapangit ng recording ko sa first few slides. So I'm very sorry about that one. Okay, so please prepare for a quiz next week. So I hope you study. I hope okay lang din kayo. Congratulations everyone for a very successful fellowship night. Okay, I hope nag-enjoy din kayo. But now, back to reality study na naman tayo. Okay? So, that's all. Thank you everyone for listening and happy Aral.